Members, guests, colleagues, friends, and family, welcome to the 100th annual meeting of the American Association of Thoracic Surgery in its virtual format. First, I would like to say that I'm humbled to be standing before you as the president of this prestigious society. As your 100th president, I do feel a burden of legacy to those who have preceded me and who through their service made this one of the great and admired professional organizations in the world. So in many ways, the task forward is clear: to make the AATS even greater. And to this end, I believe the cornerstones are the scholarship of our membership and the education of our residents and students of thoracic surgery. The components of the educational process must include not only the technical aspects of surgery, but also those aspects of professionalism which are continually threatened by the administrative burden, government oversight, and financial demands of today's practice. We must not forget that it is a privilege and a sacred trust to care for a patient at a time when they are most vulnerable. Cardiothoracic surgery has been an amazing gift to me. The journey to become a CT surgeon required commitment, tenacity, and rigor. I had many role models and mentors who aided me along the way. My father and mother were great role models. They encouraged me to dream, gave me a work ethic by example, and made sacrifices to ensure my education. It saddens me that they cannot be here today and share this moment. Dr. John Sawyers, Chief of Surgery at Vanderbilt University during my residency, demonstrated the confidence of a mentor in his mentee. I was the chief resident on Dr. Sawyers' service and was called to the emergency department to see a patient. To my surprise, underneath the white sheet lay Dr. Sawyers with complaint of abdominal pain. He assured me that it was only a kidney stone, and with intravenous fluids and some pain meds, he would be okay. I did an exam, found a very tender right lower quadrant. I explained to my chief that I thought he had appendicitis, which he promptly dismissed. I ordered an intravenous pyelogram, which showed no kidney stone. I returned to his bedside with the news and thought he should be taken to the OR. He agreed. Much to my surprise, however, he pointed to me as his surgeon. To explain further, his brothers-in-law were very famous general surgery and vascular surgeons in Nashville. Obviously, I had some concern, but he would not change his mind. He said, "I trained you, and I know I will have a great outcome." He obtained emergency privileges for me, and off we went to the OR. Much to my relief, a very inflamed appendix was found and removed without incident, other than my gastric reflux. Although it was just an appendectomy, it demonstrated to me the ultimate bar in surgical education: the pupil operating on the mentor. Among all my mentors, and there have been many, Dr. Norman Shumway, our 67th president, has been the most influential. In 1981, I recall a presentation by Dr. Shumway about the first heart-lung transplantation that had just weeks before been done at Stanford University by Dr. Bruce Wrights. The description of this first was inspiring, but it was equally inspiring to watch a proud mentor describe the accomplishments of his student, Dr. Wrights. I was a fourth-year general surgery resident, and I knew I wanted to be a thoracic surgeon and to be a pupil of this great mentor. I was fortunate and began my training at Stanford in 1984. My 3 years of training at Stanford exceeded all my expectations. I was a student of Dr. Shumway and also his talented faculty: Drs. Stinson, Oyer, D. Craig Miller, our 88th president, and Scott Mitchell. In his presidential address, some thoughts from the other side of the table, or the last presidential address, Dr. Shumway's teaching skills as the world's best first assistant were clearly outlined. He always insisted that the hardest part of surgery was getting to do surgery. His operating room was a wonderful teaching environment, and his blend of humor and attention to detail to ensure the best possible outcome for the patient is remembered by all of his students. His ability to coach a resident through a surgery with complete calm and control left an indelible imprint on me. I tried to pass on these Shumway techniques of teaching to my residents at USC. I would like to thank my faculty and staff in the Department of Surgery, the divisions of cardiac and thoracic surgery at USC, and the faculty at Children's Hospital Los Angeles, whose support has made this day possible. I would like to thank my administrative assistant, Claudia Guzman, for all of her assistance, and the administrative team of the AATS, who have been so helpful this year. Lastly, but most important, my family. Julie, You've been the wind beneath my wings this year, with your understanding and support during the long hours at the office and my absence from home by travel. Thank you. My children, Kristen and her husband Jeff, Ashley and her husband John, Meg and her husband Julian, Rich and his wife Corey, Chris and her wife Carrie, Andrew, and my 11 grandchildren. Thank all of you for your support. I'm going to spend the next 40 minutes discuss the following. First, I'm going to review the history of the AATS because I think a brief history of our heritage is important to set the stage for the understanding the essential cornerstones of the AATS: scholarship, innovation, and education of residents and students. We must remember that the prism through which we look at the past is often a template for the present and the future. Then I'm going to review the history of the surgical educational programs in America. Although our field of thoracic surgery has expanded exponentially, our training paradigms have remained rather stagnant. To understand more fully why this might be, I think a review of the residencies in America should be presented. Then I'm going to talk about the history of our surgical programs as it relates to the challenges that we face with our current training paradigms. Last, I would like to discuss the factors that I think should be considered as we move forward to improve our current training models. As I go through this review, I want all of you to ask yourself this question: what changes have you made to your training program over the past 5 years? Thoracic education has always been one of the cornerstones of the AATS. From its founding in 1917 by Willie Meyer, the mission has been to bring those physicians interested in diseases of the chest together for discussion and exchange of information for the betterment of their patients. Dr. Meyer had given a paper in 1913 at a clinical conference of the AMA entitled Extrathoracic and Interthoracic Esophagoplasty in connection with resection of the thoracic portion of the esophagus for carcinoma. And much to his dismay, there was no discussion. He believed that this new evolving discipline needed its own society formulated by physicians and surgeons interested in diseases of the thorax. Over the next 4 years, Dr. Meyer spurred colleagues interested in thoracic diseases to form a New York Society of Thoracic Surgery. They met on February 20th, 1917 at his home on Madison Avenue in New York. There were two tasks. First, to establish the New York Society, but more importantly, to establish a national society. The first meeting included 20 members, as dictated by Dr. Meyer. There was a surgeon, radiologist, pulmonologist, endoscopist, physiologist, and internists caring for patients with tuberculosis. A committee was immediately formed to scour North America for men who had published in the field of thoracic surgery and related fields, and to invite them to New York City for the formation of the American Association for Thoracic Surgery. This meeting occurred on June 7, 1917 at the Hotel Waldorf Astoria. Another 42 names were proposed for membership. Dr. Meyer's dream of a national society was taking shape. The following specialties were included: anatomy, physiology, pathology, internal medicine, inclusive of tuberculosis, gastroenterology, endoscopy, anesthesia, and surgery. Interestingly, the first president was Dr. Samuel Meltzer, a physiologist and internist who had written extensively on intratracheal positive pressure, intubation, and its aid in opening the thorax for surgical procedures. These pioneers had formulated a society where they could come together at an annual meeting to discuss and exchange ideas for the care of patients with thoracic diseases. At this time, the topics were mainly tuberculosis and empyemas. Their dream was that the diseases of the chest would gain equal importance to those of the abdomen. The modern surgical residency as we know it can be traced back to William Halsted and the Johns Hopkins training program. With the opening of the Johns Hopkins Hospital in 1889, William Halsted, William Ulcer, and Howard Kelly had established residencies in surgery, medicine, and gynecology. These residencies were the first in America. Prior to that time, advanced training in medicine had to be obtained in Europe, mostly in Germany and France. The Hopkins residencies were established for the scientific study of the physiologic consequences of diseases. Thus, training had finally entered the university. As stated by Osler, the residency is only for a few superior men wishing to do scientific work. I apologize to women here today. He said this in 1889. Clinical work, as they saw it, was a byproduct of this intense study. The residency was set up as a 12-month internship, and if the candidate proved worthy, a second year of residency, and ultimately a chief residency serving as attending staff for an undetermined period of time. The surgical residency was an apprenticeship model where the chief resident served until the faculty thought he was ready for independent practice. The clinic units were residency run, faculty supervised. The residents would diagnose, plan a course of treatment, and operate. To ensure that only the best became chief residents, a pyramid structure was in place such that only a few of the interns actually finished as chief residents. It was during these early years, as medical information was expanding at an exponential rate, that surgical subspecialties were recognized. Halsted recognized early that in-depth knowledge of a particular field demanded a subspecialization. He appointed Hugh Young into urology, Samuel Crowe into ENT, William Baer into orthopedics, and directed Harvey Cushion and Walter Dandy into neurosurgery. Thus began the differentiation of surgery into subspecialties for concentrated study. Surgical training in the 20s and 30s was vocational training in most institutions. The Johns Hopkins model, with its focus on research and clinical investigation, ensured that residency training had entered the university model of graduate-level training and physician competency. The goal as stated by the Hopkins faculty was not to produce scientists or practitioners, but rather scientific practitioners. The educational objective was for all residents to develop a spirit of inquiry, rigorous intellectual honesty, and intellectual dissatisfaction for present knowledge. I would refer any of you interested in this topic to Kenneth Ludmeyer's book, Let Me Heal. The model of training became very popular and brought great recognition to the Johns Hopkins Hospital. Other centers adopted this model, such as the Peter Bent Brigham, the Massachusetts General Hospital, the New York Hospital as a teaching hospital for Cornell, Washington University at St. Louis, Vanderbilt, and Stanford. The centers were often established by trainees of Johns Hopkins. The model had been set up that the intern and the first-year residents did the bulk of the clinical work, the chief resident and the faculty did the investigative laboratory work, taught medical students, and administrated. As America was increasingly becoming more urbanized in the 1920s and 30s, these hospitals had an ever-increasing demand for clinical work. More and more patients were being admitted, and a better understanding of diseases and treatment resulted in shorter hospital stay. Thus, more clinical demand. This had a ripple effect. Residents had less time for clinical investigative work, and residencies were expanding to meet the clinical need. The focus on scientific discovery was being sacrificed by increasing demand for clinical work. By 1940, graduate medical education was a major commitment of every medical school faculty. Hospitals also had to recognize the importance of the residency program in that it often brought an elite status to their institution. From 1900 to the beginning of World War I, resident staff was a luxury in most hospitals. But by World War II, residents had become a necessity. Every hospital now needed a resident staff, and the expansion was accelerating. The expansion came in, with the expansion came inconsistencies in the program quality. Much like a Flexner report of 1910 for medical schools, a setting of standards for residency programs was needed, none more than in surgery. During the 20s and 30s, there were several different paths of obtaining a certificate to operate, with wildly varying standards. Most vocational schools required as little as 3 months operating on a cadaver and an animal, and they would then grant you a certificate. Obviously, standardization for public safety had to be done. With the support of the American College of Surgeons, the American Board of Surgery was established in 1937 to standardize the training of surgeons in America. The ABS established criteria of training length, diversity of cases, and number. They then established the written and oral exams to be given to candidates who had finished these approved programs. After 1942, this was the only pathway to becoming a general surgeon in America. Residency programs had matured in the 30s and 40s, and none more than surgery. With sterile technique, better surgical techniques, and instrumentation and anesthesia, surgery was offering dramatic outcomes for patients with intra-abdominal processes, such as appendicitis, colitis, cholecystitis, and even early-stage cancer. With improved outcomes and better training, the public trust was at an all-time high. The general surgeons of the 30s and 40s did not think these skills were confined to the abdomen, but equally applicable to the thorax. This debate between those that believed thoracic surgery needed its own board and training program was highlighted in the 1936 annual meeting of the AATS. Dr. John Alexander delivered a presentation on training of the surgeon who expects to practice thoracic surgery. He described the ever-increasing complexity of cases now being treated in the thorax, that many were being performed by surgeons of little training with poor outcomes. He believed 2 years of intensive training in a very active thoracic unit was required, and possibly a third for desired competency. At the same meeting, Dr. Evarts Graham delivered a presentation outlining thoracic training and from a general surgeon's perspective. As Dr. Graham had been instrumental in establishing the American Board of Surgery, he held the very first certificate. Dr. Graham believed that separate board was not desirable, and if one were to be established, it should require general surgery boards first. Thus, these two papers set the groundwork for establishing of training requirements for thoracic surgery. In 1936, thoracic surgery involved surgery of the lungs, esophagus, and mediastinum, no vascular, and cardiac. Although limited in scope compared to today, recommended training involved completion of general surgery, then 2 to 3 years of thoracic surgery. Sound familiar? However desirable, most hospitals could not support a separate thoracic program at this time because of case volume and the fact that cases that were available were being treated by general surgeons. Thoracic surgery matured during World War II due to chest injuries that were now being seen due to better evacuation and transfusions from and in the field. Drs. Thomas Buford, Paul Sampson, and Lyman Brewer were surgical leaders who made many contributions to the field during this time, such as the explanation of wet lung, anatomic exposures, and vascular control in the chest. These three surgeons would later become AATS presidents. In 1948, the Board of Thoracic Surgery was formed with the support of the AATS, the American Surgical Association, the American College of Surgeons, and the surgical section of the American Medical Association. Residency training required 2 years of thoracic surgery training and programs approved by the Board of Thoracic Surgery and the completion of an improved general surgery program. The case mix and numbers of cases were not mentioned initially. As thoracic training expanded to include an ever-increasing volume of cardiovascular cases, the requirements became more rigid. Initially, a candidate could meet the requirements for dual certification in general surgery and thoracic surgery by completing a number of thoracic cases in his or her 5th year of general surgery training. But this pathway would go away. In 1969, the Board of Thoracic Surgery adopted a provision requiring 12 months of senior responsibility in thoracic and cardiovascular training. In 1971, the independent board of the American Board of Thoracic Surgery was formed. Further clarification of training experience occurred in 1973 when the RRC defined the minimal numbers and diversity of cases that a trainee should perform in a graduated fashion. The minimal number was set at 100, with 15 to 20 involving the lungs and pleura, 30 to 40 cases involving the great vessels and heart, with emphasis on using cardiopulmonary bypass. 5 to 10 cases of the esophagus and diaphragm were recommended. The RRC, with the approval of the ABTS, had now clearly outlined training expectations. As thoracic training was being defined, residency training in general was facing new challenges. With the enactment of Medicare and Medicaid in 1965 and the rise of private insurers, medical care was now available for more Americans in a more private setting. Wards with 12 to 14 beds were disappearing rapidly. Large safety net hospitals, such as Los Angeles County, were seeing fewer patients. These residency-run clinics, the bedrock of residency training, were rapidly disappearing. The resident-run clinics were often the only care the indigent patient had. The graduated responsibility for the care of these patients was an important component of the resident's educational experience. The teaching hospitals provided a sense of service to the patients. Patients trusted the system. They believed the residents and the attending staff would do right by them and solve their medical problems to the best of their ability. Although Medicare and Medicaid did diminish the undesirable effect of a two-class medical system, it did impact training. With the increased access to medical care, the hospital occupancy and revenue grew exponentially, creating increased work for the resident. The demands for service began to challenge the quality of the residency education. With federal funds came an increasing amount of paperwork, documentation. Suddenly, the resident was admitting and discharging increasing volumes of patients. The impact on surgical education was dramatic. Time for investigative inquiry and patient care had been transformed into ordering a battery of tests to cover a particular organ system, hopefully not missing anything, and then passing the information up the command chain. Surgical residents had less time to be in clinics or to understand why a particular operation was being recommended. Rather, a patient often appeared on the OR schedule with a diagnosis and procedure. This approach violated all principles taught by Halstead. A good surgeon knows when not to operate as well as when. In this changing paradigm, the resident had little time to contemplate this important part of his or her training. America was now experiencing unsustainable health care costs. From 1965 to 1990, health care costs had risen from 4% of the gross national product to 11% and showed no signs of slowing. In response, the federal government introduced a diagnostic-related groups. Hospitals would now be paid in a set payment in advance for a particular diagnosis, rather than after the fact for billed charges. The impact was a reduced hospital margin and more stresses on residency education. Residents were now seeing even more patients with hospital stays of 2 to 3 days, which before DRG would have been 4 to 6 days. The consequence was more work, ever-increasing service over education. This resulted in longer work hours, less educational value, less interaction with attendings, and an overall feeling of underappreciation. The 80-hour work week can be seen as a result. Patients also became concerned about the care being rendered by these tired residents. Patients were not so concerned about the residents as they were about getting suboptimal care. To make matters worse, the medical school debt of most graduates was rising dramatically. By 2004, their average graduate owed between $105,000 and $150,000. The culmination of these factors produced disaffected residents who wanted to complete their training as soon as possible. During this time, there was a paradigm shift from professional education to training, practicing algorithm medicine and surgery without the why. This was a clear departure from Halstedian principles of residency training. Also occurring was the breaking of the sacred trust that medicine had enjoyed. With rising healthcare costs and overworked residents and staff, patients felt they were receiving a diminished level of care. A rising dissatisfaction with healthcare delivery became a public debate. I now have gone through what was happening in American residency training from 1889 to present. These factors also directly affected training of thoracic surgery. The challenges of increasing patient volume, decreasing physician extenders due to cost containment by hospitals, increasing complexity of patients, and the 80-hour work week are threats to our residency. We as educators now, as never before, need to think creatively about how to train the next generation. Our training paradigm in thoracic surgery has changed little over this period of time, and yet our clinical practices have been impacted by these external influences and by an explosion of technological advances, both in cardiac and thoracic surgery. We need to attract the brightest and best men and women to thoracic surgery. We will not succeed in training programs if they remain the same. Generations change and value systems emerge. Baby boomers put work and career ahead of personal gratification. Generation X and millennials do not share the preoccupation with work that the boomers did. Life balance is very important to this new generation. They want to have families, attend their children's soccer games. In training the next generation, we have to keep this in mind. Interestingly, this is just important to men as it is to women. If we are the Halsteads of the 21st century and are tasked with designing the new training paradigm for thoracic surgery, what are the factors to be considered? First, the length and composition of our training. Second, how do we train the next generation of academic leaders and mentors? Third, how do we recruit the next generation with an emphasis on diversity and inclusion? And fourth, how do we resolve professionalism as a basic tenet? This is not to be all-inclusive, but highlights some of my personal thoughts. First, I'd like to discuss the length and composition of training. The average length of training after medical school for a thoracic surgeon is 8 years. In a workforce survey by Sheeman and Economides, 25% of adult cardiac surgeons, 56% of congenital heart surgeons, and 32% of general thoracic surgeons reported training exceeding 9 years. And if we break down the years of training, most spent 5 years in general surgery before thoracic surgery. Although I believe the number of years can be shortened, a substantial decrease is unlikely if we want to train the very best thoracic surgeons. However, the time spent needs to be carefully reevaluated. Given the changes that have occurred in general surgery, 5 years spent learning techniques of stapling the bowel, liver resections, and Whipple procedures is not time well spent. However, we do need to work with general surgery in the first 3 years to design rotations that work for thoracic surgery trainees and do not disrupt the overall general surgery rotations. The constant paradigm shifts of clinical care demands more flexibility in our training programs, and therefore more focus on deliberate training in thoracic surgery. We need to offer training programs that can be modified easily as our clinical practices change and as technological advances continue. As often been said, the only constant is change. I would propose a 6-year training program with an optional 1 to 2 years of research for those residents pursuing an academic career. The first 3-year block of training would be dedicated to basic surgery and cardiovascular training. During this first year, residents would spend 7 months on general surgery services, learning critical care, acute care surgery, and trauma. The next 5 months would be spent on basic cardiovascular rotations, where we would teach the basic skills of opening the chest, cannulation, and vascular suturing. Cardiology rotations, including cath lab and echo reading, would be offered. During the second year, 7 months of general surgery would be again offered in basic patient care areas, as well as some of the surgical subspecialties, and then 5 months of cardiac and cardiology rotations. During this year, rotations in congenital heart, perfusion, and wire skills would be offered. In the third year, 3 months on general surgery performing acute care surgery, and 9 months on thoracic and cardiovascular services. The first 3 years will produce a resident who is competent with acute surgical care and be armed with basic cardiovascular and thoracic skills. After 3 years, residents may elect to spend either 1 or 2 years in research. At USC, a structured program is in place to give courses in statistics, grant writing, and research conduct as outlined by the NIH. We believe this program prepares the residents for a career in academic surgery. On average, each resident completing this program has produced 3 clinical papers with at least 2 podium presentations. This is a year spent with a mentor. The resident is exposed to a role model in academics with the hope of stimulating an increased interest in investigative research. The last 3 years are clinical years with graduated responsibility. The resident sees all aspects of cardiac surgery, transplantation, cardiac support devices, and thoracic surgery. The resident operates early in their 4th year, and in years 5 and 6 are usually the operating surgery. We believe that this produces a thoracic surgeon who is both a good doctor, surgeon, and scientist. I've often challenged our faculty about residency competency. The litmus test for me involves 3 questions. Would you hire the graduate as a faculty member? Would you let the graduate operate on a family member? Most importantly, would you let the graduate operate on you? If the answer to these questions is yes, then the ultimate bar of competency has been reached. Much like Dr. Sawyer's challenging me to be his surgeon, this ultimate bar has remained my goal in residency teaching. As outlined, the length of training could be abbreviated and the composition would be more focused on cardiothoracic surgery. If we want to track the very best, our training has to be focused more quickly on the specialty these millennials have chosen. With increasing debt out of medical school, these residents want to be focused early and finish quickly as is reasonable. This model of training, which the predominance of postgraduate training is spent in your chosen specialty, seems optimal to me. As our specialty becomes more highly specialized, this extra time can be used for specialized training tracks within our overall training program. As is currently being discussed by the AATS, training tracks for thoracic, adult cardiothoracic, and adult structural heart disease could be easily accommodated. It is important that we take responsibility for training our residents and not leave it to another specialty. Adult cardiac surgery is becoming more catheter-based, which is integral to the future practice of cardiac surgery. There is a debate about who should train the next resident in these skills. The practice of surgery over the past 100 years has changed dramatically. We've gone from TB surgeons to surgeons performing highly complex cardiac and congenital heart procedures with cardiopulmonary bypass. With each incremental and sometimes revolutionary technological advance, we've been able to, as a discipline, teach the next generation those needed skills. Hopefully, we also taught that surgery and medicine in general are dynamic and will continually change in practice. We are currently at another point of technological advancement, catheter-based intervention. There's much debate about who should train the resident in these skills. As thoracic surgeons, we are uniquely positioned to train this technology because we understand the underlying pathology. We know what a highly calcified bicuspid aortic valve looks like and why a transcatheter approach may not be the best option. Whereas if I've never seen this valve, my decision-making between surgical versus catheter valve may be influenced by my personal goals and ability. Catheter-based technology will impact not just valvular heart disease, but aortic pathology. Endo-aortic stenting has revolutionized complex aortic pathologies of dissection and aneurysms. Operating on patients with ascending and descending aortic diseases can now be accomplished routinely by combining open ascending and arch debranching with distal frozen elephant trunk, setting the stage for future aortic stenting. In the recent past, this operation carried out with open technique would have had high morbidity and mortality. Now, using endovascular procedures combined with the open procedure, the expected morbidity and mortality is much lower. These complex operations are being taught to our residents employing the wire skills that they will need in the future. The wire skills needed to negotiate the arch and head vessels are applicable to the aortic valve. The merits of a fellowship in structural heart disease after CT training have to be carefully analyzed. Is the objective to gain a skill we believe we cannot teach, or access to patients we think we will not be available? A year is a long time to let the camel keep his nose under the tent. Remember, our goal is to shorten as best we can the training of the residency. Our next topic is training the next generation of academic leaders. This may be our greatest challenge, and it is certainly the most important. In the current era of managed care, increasing demand for shorter hospital stays, cost cutting by decreasing the number of physician extenders, and greater administrative overhead, the resident has assumed an increasing service role at the expense of their education. The time spent for cognitive pursuits is continually under assault by clinical demand. For example, the topic on surgical rounds is often not about the latest article on prosthetic valve endocarditis, but on the disposition of the patient, going home with family or to a skilled nursing facility. The triage of patients is an increasing role of our residents and has little educational value. If this environment is to change, we have to be part of the solution. We have to advocate for more physician extenders, more administrative help on the floors for patient triage, and in some circumstances, increasing our residency pool. Mentoring and role model are key to fostering interest in academic surgery. We have to stimulate excitement about presenting at the next annual meeting of the AATS. We have to take an interest in their research, help them achieve success. And once they have experienced the thrill of that first podium presentation or that first paper accepted with their faculty mentor, most will be hooked. I can remember my first presentation on lobar lung transplantation at the 75th annual meeting. I was very excited, but more so because in the audience was my mentor, Dr. Shumway. Those moments you never forget. Time for reflection, discovery, have to be part of our training programs. A year or two spent doing productive research is a platform from which the next generation of academic leaders will be launched. Stay engaged with your residents. Show interest in their work. Celebrate their accomplishments. This is a culture that will produce the next generation of leaders. Recruitment to our specialty with focus on women and minorities. The number of women entering medicine has been steadily increasing. In 2017, women surpassed men enrolled in U.S. medical schools, making up 51% of the student body, compared to 9.3% in 1965. This is a pool of medical students we have to attract to our specialty. We note in the last AATS survey that 48% of practicing surgeons in thorax have made that decision while they're in medical school. We at USC have certainly seen great enthusiasm for the I-6 program among highly qualified medical students. We have to reach into the medical school classes and convince this growing female workforce that a career in CT surgery is a great career. Lyons et al. Reported that with increasing numbers of female medical students, women going into surgery has also increased from 15% in 2000 to 24% in 2016. However, during the same time period, women going into thoracic surgery has only increased by 3.2%. The statistics for minorities going into medicine in general is dismal. African Americans and Hispanics represent 14 and 17% of the U.S. population respectively. However, they represent only 4% of the physician workforce. If we look at current trends in the U.S. medical schools, although improving, the number of African American students represent 4.6% and Hispanics represent only 5.7% of the graduating medical class. The challenge here is far greater due to the smaller numbers. We are to recruit women and minorities to our specialty. We have to understand more fully the barriers. Borrowing from the STS workforce on diversity and inclusion, Cook et al. Identified 4 frequently cited barriers for women and minorities from entering CT surgery. First, lifestyle concerns for career in CT surgery as it related to family planning. Second barrier was a lack of women and minorities as mentors and role models. Third, a lack of exposure to CT surgery for women and minorities at the medical student and surgery resident level. And fourth, a perception of an unconscious bias by CT programs toward women and minorities. Lifestyle concerns don't just affect women and minorities, but the majority of medical students entering the workforce. The 80-hour work week has been helpful for students thinking about surgery. We must explore more flexible training paradigms for women and with families or planning to have families. A simple but important first step would be to provide child care in our hospitals or nearby facility for female and male residents. This is often a major hurdle when money for child care is very limited. The lack of mentors and role models need to be actively addressed. With more women and minorities currently entering the surgical workforce, over time there should be more women and minorities in leadership positions. This pipeline effect has often been an explanation for so few women in leadership, i.e., so few women have entered, so why would you expect them to be now leaders? Well, looking closer, Donington and colleagues found female CT surgeons accounted for 61% of assistant professors and 18% of full professors, representing a larger fall-off than expected. Cardiothoracic surgery leadership has to be constantly vigilant to provide support and encouragement to our young women and minority faculty members. We need to place them on local medical school committees, promote national organization involvement, encourage their involvement in annual program planning, and propose them for moderators at sessions. We as role models have to make them more visible to the academic community and help them realize this great resource and potential for our specialty. The importance of diversity has been documented in many disciplines. Businesses with women and minorities on their staff and boardrooms consistently show better financial performance. In surgery, women leaders have brought positive changes, including the promotion of diversity and inclusion, championing pay equity, and addressing issues such as well-being and burnout. As the population in the U.S. has become more diverse with more women in medicine, it's imperative for our specialty to be more inclusive. The AATS Leadership Academy last year assembled a group comprised of future women and minority leaders to discuss issues related to career satisfaction, academic promotion, life balance, and how to attract more of them into our specialty. I believe the AATS will play an important role in making CT surgery more inclusive. Just as we were founded on being inclusive of all disciplines related to thoracic surgery, I'm sure Willie Meyer would encourage us to be more inclusive in our membership. I do have a pertinent disclosure, as I am a proud father of an academic woman surgeon. Professionalism. I think we all have heard of the erosion of the social contract between medicine and society. The establishment of that contract was at its peak during the first half of the 20th century. This era was noted for the discovery of new medicines such as insulin that produced life-changing results. In cardiac surgery, the blue baby operation, the first attempts at intracardiac repair, valve replacement therapy, and coronary surgery were all important technological advances that changed people's lives. As a result, there was a goodwill from the American public for medicine and doctors. A social contract had been entered. There would be public funding for the ever-growing healthcare cost as long as the product, good healthcare, was provided. Over the next 35 years, from 1965 to 2000, there was an erosion of that trust. Best-selling books began to appear with titles such as How to Survive Your Doctor's Care, Surviving Healthcare, and my favorite, How to Get the Same High-Quality Healthcare Your Doctor Gets. Why had this happened? During this period of time, there was a double-digit healthcare inflation. Various models of HMO had entered as a way to control cost. What got lost during this time was the patient and the doctor-patient relationship. As a profession, we were on a treadmill to see more and more patients and do more and more procedures to make up for declining revenues. Academic faculty were being replaced by clinical productive faculty, and the teaching mission was being threatened. Patient encounters with their physician would often be brief, and the patient would leave with the feeling they were not heard. As thoracic surgeons, we were guilty of expecting a patient flow from cardiologists already with the diagnosis, aortic stenosis, coronary disease, and we would provide the necessary procedure. That pipeline seemed secure as long as the cardiologists were not involved in the treatment, that is, providing a procedure. We now find ourselves potentially competing with cardiologists for the patient. This is not the environment we want to be in, nor is it the environment they want to be in. We must remind ourselves that patients do not exist for the benefit of the doctor. The doctor exists for the benefit of the patient. As catheter-based technologies have brought cardiology and cardiac surgery together with options for valve replacement, TAVR or SAVR, we must always advocate for the patient without our self-interest as a determinant. As this type of therapy is becoming mainstream, transparency and honest reporting of the data will be demanded, such that appropriate therapies can be recommended. We as thoracic surgeons will have to provide leadership and be watchdogs as the cardiovascular therapeutic space moves forward. The AATS will be integral leaders moving forward. And I am reminded of a quote: leadership is not the private reserve of a few charismatic men and women. It is the process that ordinary people use when they bringing forth the best from themselves and others. This will ensure that the future patients will receive the best therapy. If we remain strong advocates for our patients, our specialty will have reestablished the social contract, which will ensure our future. I have outlined what I believe the cardiothoracic training programs of the future should look like. I've also delineated some of the challenges we'll have to address. Length of training, increasing recruitment from the increasing pool of women, professionalism, and training the next generation of academic leaders. To conclude, I would ask each of you one last question. Why do we, the AATS, exist as an organization? My answer as your president is to promote scholarship, education, and research for the benefit of our patients. And I do believe our membership will be critical to modifying training programs to address thoracic surgical education and a changing paradigm. Thank you.